Like the rest of the UK, Edinburgh and South East Scotland is facing a number of health and social care challenges. These include an ageing population, more people living with long-term conditions, and increasing costs of medicine. DataLoch exists to help tackle these problems, using data to enable improvements in public health and social care through supporting care services, research, and innovation. How does this actually work? Whenever anyone interacts with health and social care services, such as visiting the hospital, going to community health facilities, or having a social worker visit, useful data are created and collected. Right now, it is difficult to bring these data together. This is where DataLoch comes in. The DataLoch team works with a select and trusted group of health and social care professionals to bring these data together securely to make sense of them, and then to use them to enable population-wide insights that benefit everyone in the region. We only work with the right people for the right reasons. We uphold the highest standards in data security. The data that DataLoch hosts are de-identified and only shared with trained and approved people. Guided by our 5 core principles in everything we do, we make sure the people who access our database use it to find new and innovative ways of delivering and, most importantly, improving health and social care for all.
Asthma affects 5.4 million people in the UK. Evidence from the Asthma UK Centre for Applied Research has found that digital tools could improve people's medication adherence, their asthma management and control, and their quality of life. We are asking asthma researchers to do 3 things. 1. Make sure that people with asthma are involved at all stages of research studies, including driving new ideas for research. 2. Collaborate with digital technology innovators to combine new and existing research and evaluation methods. 3. Collaborate with health technology companies and work with healthcare regulators to support implementation into practice. Respiratory research matters.
Each time we visit the doctor, go to hospital, or make use of social services, we generate data. These data can be the foundation for crucial improvements in public health and social care services. However, before these improvements can happen, the data need to be understood, brought together, and securely accessed by approved people. This is where DataLoch comes in. We identify available datasets from numerous locations and bring them into our database. We capture the meaning of the data and how they were produced. We tidy the data to make things easier for researchers. For example, standardising the different codes GPs and hospital physicians use to refer to the same conditions. Last, we work with clinicians to confirm we have correctly captured the meanings and accuracy of the data. Through this robust cycle, DataLoch saves researchers time and effort in making the data research-ready, ultimately leading to improvements in health and social care for all. Visit our website to discover more about how DataLoch enables improvements in health and social care.
So I'm Luke Daines, I'm a GP by background and also work as a researcher. I'm currently a postdoctoral research fellow at the centre. So PPI, patient and public involvement, has been really helpful throughout a lot of the projects I've done. I think when I applied for a PhD fellowship, I was able to have a person who had experience of living with asthma come on board and really give me feedback on my initial ideas and help me to improve the quality of my proposal and make it more relevant to them and individuals with asthma. I think as I started to get results from that study, I was able to talk them through with that person and others as well, and to get a feel for how important they were and interpret them jointly. And I think the final part of my PhD was an end of project workshop where I was able to tell people about the results and try and gain some context for them in implementing it and the next step. And I think having patients and parents of children with asthma in and around that discussion was just super, because it really helped to get a feel for what the relevance to them. So I think having PPI members as part of research has made a really great impact on the projects that I work with and the wider groups that I'm part of. I think it just makes sense, doesn't it, that you have people who are either directly affected with a condition or have family members or direct lived experience of an illness. You know, to have them feed into research it makes so much sense. And I think the projects are so much stronger for their involvement. I think what I've learned is how to really make the most of their expertise and how to bring them in the best possible way. And so the PPI group within the centre have been great for that, because it really helps to make sure we're speaking the same language. And so really the impact is throughout the project. So from designing it and coming up with research questions, designing the study, thinking about the outcomes that are most important. Then when you start to think about the findings, what does that really mean and how important are they? So interpreting that. And then also how to share the findings in a way that is much more powerful, because researchers are not always great at sharing what they find in a really meaningful way. And so PPI members can be just great at saying, well, what actually is it you want to tell us and what's important here? So yeah, I think it's been a really great experience, and I'm looking forward to continuing to work with the PPI group.
Longitudinal studies gather data about people's lives over time. This data can lead to discoveries that improve and save lives. There are millions of study volunteers across the UK, and as the pandemic took hold, studies realised if they brought their data together and linked it with other data, such as health or education, it would create a national research resource. The UK Longitudinal Linkage Collaboration, also known as the UKLLC, is the UK's trusted research environment for longitudinal research. You may have some questions, like how will this work? How will the data be used? And will this work make a difference? Where studies agree, UKLLC links studies data with study volunteers' other data, such as official health, education and occupation records, and data related to where they live. Partner studies will send de-identified study data through protected channels to the University of Bristol's secure research server. The studies and UKLLC will work with the NHS and statistical authorities to link official records. This will be done securely, using unique ID numbers for each study volunteer and high levels of data security, so the data is de-identified. When volunteers join a study, they can ask questions about how their data is used and the value this can bring for research. Study volunteers can opt out or change their mind from having their data shared with UKLLC by contacting their study. Approved researchers will request access to this data. Only requests that aim to benefit the public are approved. For every application to use this linked data, study committees decide if their data is included. We hope to find out more about the health and well-being of people living in the UK. It could help inform things like how we understand and treat health conditions, and identify which groups in our communities may need access to mental health support and much more. Study volunteers are providing an amazing amount of data. By bringing this data together, we're providing a way for research to meet the needs of all people across our communities.
Nothing matters more to us than keeping data about you safe, protecting your identity, and making sure we enable trustworthy projects with the potential to improve health and social care for all. We achieve this through a multi-layered set of data security principles, known as the 5 Safes framework, developed by the Office for National Statistics. This means we work with trained and approved researchers who have signed up to strict data access guidelines. We also make sure every project has clear public value, uses data appropriately, and adheres to our ethical principles. We actively minimise the data so researchers see only what they need and no more. We also remove key personal information to de-identify the data. We then grant researchers time-limited access to specific data held in a highly secured digital environment. Last, we check that individuals cannot be identified, even indirectly, in any outputs. Together, the layers of the framework keep data about you safe and ensure access is granted only to the right people for the right reasons. Visit our website to discover more about how we protect the health and social care data we host.
My name is Bohee Lee. My PhD study was based at the University of Edinburgh at the Asthma UK Centre for Applied Research. Coughing and wheezing are very common in young children and are usually caused by a virus. Wheeze in children 1 to 6 years of age is often called preschool wheeze. Most children will grow out of preschool wheeze as they get older, but some go on to have asthma. Children who develop severe wheeze are often given a steroid medicine by mouth. There is still a big debate on whether oral steroids work in treating preschool wheeze. My PhD. My study was looking at the effects of oral steroids on preschool wheeze using data from studies already done but analyzed in a different way. I wanted to find out if oral steroids help children with preschool wheeze get better faster. To find out the answer, I did a meta-analysis which is comparing all the studies about oral steroids for preschool wheeze and bringing together the results. There were 11 studies that we are able to use the results from, but I had a problem. The studies included different age groups and different ways of analyzing the data. To resolve this issue, I requested anonymized individual data about each child from the researchers who did the trials. This way, I could look at all the individual children's data instead of the summary data from each trial. I also interviewed parents and doctors of children with preschool wheeze to find out what their treatment priorities were. The results of my PhD. I had 5 main findings from my study. I found that oral steroids, 1, had a benefit in reducing wheezing symptoms within 4 hours, 2, shortened hospital stays by around 3 hours, 3, had more benefit for children with more moderate to severe wheeze, especially those with allergies. 4, are best for emergency treatment. 5, from the interviews with parents and doctors, I found out that the wheezing severity score was the most important measure of recovery from wheeze in children given steroids. From this information, the decision to treat with oral steroids is more straightforward. So what does this mean? Oral steroids might help children get home sooner from the hospital, but might not stop them from wheezing again in the future. Doctors should consider giving oral steroids to all preschool-age children arriving at the emergency department with moderate to very serious wheezing symptoms, especially those with a history of wheezing, asthma, or allergies. If you want to find out more, see my PhD profile page on the Asthma UK Centre for Applied Research website.